My name is Dr. Anthony Caiafa. I'm an adjunct associate professor at the School of Veterinary and Biomedical Sciences at James Cook University in Townsville. And this is the third webinar in a series of 3. And the title of this webinar is Dental Radiographic Interpretation, Feline. Firstly, we'll discuss pulpal disease or disease of the root canal system in cats. If you suspect pathology in a tooth, radiographing the contralateral tooth or changing your angulation in a horizontal direction may assist you in determining whether the pathology is real or a variation on normal. Remember also you need to lose about 50% of the mineral content in bone to see a radiolucent area. And unfortunately in the oral cavity, when we are radiographing teeth, often we are shooting through cortical plate on the buccal side and cortical plate on the lingual side, and this makes areas less dense. So sometimes we are looking for not black or lucent areas, but we're looking for variations in grey. With endodontic disease of the tooth, we'll see a widening or the loss of the apical periodontal ligament space, and this is a sign of endodontic disease. Often, if the tooth became necrotic at a very early age, we'll see a widened pulp as well, and this can be compared to the neighboring teeth or to the contralateral tooth, and this also suggests pulp necrosis. As mentioned before, if you change the tube head horizontal angulation, this may change the appearance of the apical periodontal ligament space. And sometimes we need to do this to confirm whether there is apical pathology. As a general rule, borders of the lesion, if they're well demarcated, that tends to suggest a radicular cyst. Or if they're more diffuse borders, this tends to suggest apical periodontitis. This is a very good example of a complicated crown fracture in the tooth 104. So this tooth here has a pulp exposure. You can see it there. And with that pulp exposure, if we've taken a radiograph, so this is a mesiolateral view of that tooth, you can see that the pulp canal is quite wide. You can see how wide it is compared to, say, the neighboring teeth. And also, if you look at the blue circle there, you can see that there is a suspicious widening of the periodontal ligament space. So we follow the periodontal ligament space around here. It starts to become a little bit distorted in this area here. It is very subtle, but combined with what we're seeing here, and what we're seeing here, and what we're seeing at the apex, that will indicate that we have pulp pathology and pulp necrosis. This is a similar case to the previous slide, but this is a bit more interesting. This cat actually fractured its tooth 204 when it was around 1 year of age. So this tooth has stayed in this situation for 8 years, so the cat's now 9 years of age, and the cat presented because it had facial swelling in this area. So the side of the face is swollen up, and if you look at, again, the pulp, look at the radiograph on the right hand side, the pulp is quite wide. And that also indicates that this tooth died when the cat was quite young. So you can see the contralateral tooth, the tooth 104, you can see how narrow the pulp is in this tooth compared to the tooth with pulp necrosis, tooth 204. The blue circle also shows you that there's widening of the periodontal ligament space here, but not only that, but we're also seeing inflammatory resorption. So we're getting loss of the tooth structure in this area, and so this root at the apex is starting to resorb, and because of that there's quite a lot of inflammation involved with that, and that could explain why the facial swelling has come along. Now we'll look at some cases of periodontal disease in cats. For a periodontal health examination, we look at the crestal bone between the teeth and in the furcation areas. If we lose the bony crest, this indicates periodontitis. If we lose bone in the furcation area, this also indicates periodontitis. Usually in healthy crestal bone, we have a knife edge crestal bone. If we lose this knife edge and we get blunting of the crestal bone and loss of the sharp angle between the lamina dura and the crest, or widening of the periodontal ligament space at the crestal bone area, then this is signs of early periodontitis. We have two types of bone loss in cats and dogs due to periodontal disease. One is angular or vertical bone loss, and the other one is horizontal bone loss. As a general rule, angular bone loss is more likely associated with deep probing depths. And also as a general rule, horizontal bone loss is more likely associated with gingival recession. Now we can see both types of bone loss occur in the cats, but often in the caudal area we tend to see more horizontal bone loss and gingival recession associated with periodontitis. This figure is taken from the Journal of Feline Medicine and Surgery 2015. If we look at the caudal mandible here in this cat, and this is tooth 309 here, we can see that around the distal root of tooth 309 there's vertical bone loss, or angular bone loss. You can see it here on the red lines here, down to the apex of the tooth. If we look at the crestal bone levels, now we can see that we have bone loss, especially around that distal root and extending onto the mesial root of the tooth 309. And this is more a horizontal type of bone loss in this area here and in this area here. We have angular bone loss between tooth 309 and 308. We have a more horizontal bone loss between 308 and 307. We also have a tooth resorption occurring. You can see the yellow arrow here. We have a tooth resorption occurring in this area here. And that isn't a typical tooth resorption. It's more related to periodontal disease. So this is an inflammatory tooth resorption associated with periodontal disease. From the previous slide, which we would call chronic periodontitis, we tend to see that more in older cats. We do see two forms of periodontal disease in young cats, and one is a juvenile onset gingivitis, and one is the juvenile onset periodontitis. So you can see in the photograph on the left-hand side, we have quite marked inflammation occurring around tooth 309 here, and then 308 and 307. So very distinct inflammation occurring around those teeth. Now this inflammation is localized or above the mucogingival line, and so this is gingivitis. It can be periodontitis based on our periodontal probing depths and also our radiographs. So if we see the image, the radiographic image on the right hand side, you can see the yellow dotted line. We can see that that is the actual bone level around the tooth. So you can see that we've had significant bone loss around that tooth compared to where the bone level should be. So the blue dotted line is where the bone levels should be. Also in this radiograph we're seeing tooth resorptions occurring as well, which we would suspect is associated with the periodontal disease rather than a typical tooth resorption. So you can see the red arrows here where you can see tooth resorptive lesions occurring in these areas here. So this disease is quite difficult to treat in younger cats. Some cats will just have gingivitis and get over it as they get older. So it seems that the problem is immunocompetency, and as their immune system develops more, they get over the disease. Some of these cats will progress to periodontitis, and so in this situation we would have to extract tooth 07, 308 and 309. This is another example of juvenile onset periodontitis, but this is a more aggressive form of the disease in this 1-year-old cat. If you look at the photograph on the left-hand side, you can see quite marked hyperplasia of the gingival tissues involving the canine, the incisors, and even the premolar teeth. So this is quite an aggressive form of disease. I think because of the situation that we're seeing here, and if you look at the radiograph on the right-hand side, you can see that there's quite marked bony destruction occurring around the canine and incisor teeth, and with that the amount of bony destruction, I think it's worthwhile to biopsy this lesion, take a biopsy of this lesion here or here, just to see what you're dealing with. But this ended up being a juvenile onset periodontitis, and all these teeth were extracted because of that situation. We do see other forms of inflammatory disease in the cat, and we do see eosinophilic granuloma complexes. These can occur in the oral cavity or on the lips of cats. This is an example of eosinophilic granuloma complex. You can see this marked inflammation that's occurring around tooth 409 here. We did biopsy this, and this did come back as eosinophilic granuloma complex. You can see in the radiograph in the middle here, this is the same cat. There's there's very minimal bone loss in around the distal root of that first molar tooth. There is a little bit of angular bone loss here, and there is some bone loss around the premolar 4 and premolar 3. If you also look at the image on the right hand side, this is the same cat, and we actually had infiltrative disease occurring around in the gingiva around the premolar teeth on the left hand side, and this swelling and infiltration was actually eosinophilic granuloma complex as well. Now we'll discuss a very common problem in cats, tooth resorptions. According to the American Veterinary Dental College, tooth resorptions in cats can be divided up into 3 types. Firstly, we have type 1, where we see basically a lesion that it's occurring in the cervical area of the tooth, so in this area of the tooth here, and quite a large lesion here. If you follow the periodontal ligament space around the tooth root, it should be regular, and it should be visible. So you can see a periodontal ligament around this tooth root and periodontal ligament around this tooth root. So the gold standard for tooth resorptions, the gold standard of treatment, is to remove the tooth. So in a type 1 tooth resorption, we should be able to extract the whole tooth. If we go on to a type 2 tooth resorption, we are seeing the loss of the periodontal ligament space. So you can't really follow the periodontal ligament space around the root of the tooth. There's also a loss of the radiodensity in the root structure. So this area here is starting to look more like bone. And we've still got some tooth resorptions occurring in the crown of the tooth. And these teeth end up fracturing at this level. And so these are the typical missing teeth, where there's a bulge in the gum tissue over the resorbing or replacement resorbing tooth root. So these roots will end up becoming bone. In a type 3 tooth resorption, we have a combination of type 1 and type 2. So if you look at the radiograph on the right hand side, we have a normal periodontal ligament space around that root, but we're starting to lose it around the distal root of this tooth, this premolar tooth. So in this situation, we would extract the whole tooth, but we would leave the root here to undergo replacement resorption. I forgot to mention in type 2, the best treatment for this is what we call crown amputation. We crown amputate at bone level. We try to reduce the tooth structure below the bone level, so we remove some of the tooth structure below the bone level, and then we suture the gingiva closed. This is an example of a type 2 tooth resorption. And in this situation, the crown of the tooth looks quite normal here. There is a little bit of gingival recession, so we can start to see a little bit of the root of the tooth. So we do have periodontal disease occurring here. We have another tooth resorption lesion here in the incisor tooth. But it's not until we take a radiograph that we realize how much of this tooth is actually being resorbed. So you can see the yellow oval here. We can follow periodontal ligament here and here, but then we are losing the tooth. So this is the resorbing tooth root. In this situation, a crown amputation technique to this level here, so where we can actually get down and remove the tooth to that level and then suture the gingiva closed over the top. This is another example of a type 2 tooth resorption. If you look here in the premolar area, we've got a missing tooth 407. So there's resorbing root in this area, and the gingiva should have healed over that. We have a type 2 tooth resorption. So if you follow in tooth 404, if you follow the periodontal ligament, you start to lose it in this area here. So we're losing it in all this area of the root of the tooth. We have a resorptive lesion here as well. So in this situation, again, crown amputation, we'll try to get down as far as we can in the periodontal ligament and remove that part of the tooth here, and then allow the rest of the root to undergo replacement resorption. Yet another example of a type 2 tooth resorption. If you look at the image on the photographic image on the left hand side, we have a fractured crown here on tooth 404. The radiographic image shows us that we actually have a tooth resorption occurring in this tooth as well. So you can follow the periodontal ligament to about this level. We're losing it big time in this area, and we're losing it in this area as well. So in this situation, again, a crown amputation and intentional root retention is the way to go. We do have a pulp exposure here, but there's no evidence of apical disease around the end of the root of this tooth. So in this situation, we would still do a crown amputation, because there's no way you're going to be able to remove that part of the tooth down there, because that's nearly being replaced by bone. Here we have some examples of a type 1 and a type 3 tooth resorption. If you look at the clinical photograph on the left hand side, we can see maybe there's a lesion in this area here, maybe there's something going on here, but the gingiva looks quite healthy in that area. It's not until we take a radiograph that you can see what's actually going on. So this is tooth 409 here, and here we have quite a large lesion in tooth 409. You can also see in tooth 408 that the distal root of tooth 408 is actually gone. It's being replaced by bone. You can see periodontal ligament around the mesial root here, we've got a resorptive lesion here. So this root should be able to be extracted. This would be just smooth over the bone in this area. We have a resorption lesion here. We have intact periodontal ligament around here and around here. You can see there's angular bone loss here, which is associated with periodontal disease. So the tooth 409 should be able to be extracted as well. Just the arrows there showing you the severe periodontal disease that the periodontitis that we're seeing associated with this tooth. This is an interesting example of a type 2 tooth resorption. This cat had a radiograph, had a swelling. You can see the swelling of the ventral chin here. So the cat was presented because the ventral chin was swollen. If you look at the lateral view, you can see quite marked bony reaction occurring. The yellow oval here. So you can see how marked the bony reaction is that's occurring in that rostral mandible. We do have a tooth resorption occurring here. In this situation, I did recommend that a biopsy be taken. The biopsy came back as inflamed bone, so an osteomyelitis type of issue. If you look at the anterior posterior view of the rostral mandible, you can see that we have a type 2 resorption occurring around tooth 404 and also around tooth 304. In this situation, the vet that sent me these radiographs was able to extract the whole tooth, which was quite a good idea because of the amount of bony reaction occurring in that area. And over a period of time, over a few months, the chin swelling and the bony reaction started to subside, and subsequent radiographs showed that this reaction was starting to diminish. So this was all reactive bone related to the tooth resorption. Here we have examples of a type 1 and type 2 tooth resorptions in the lower right mandible. So you can see the image on the left-hand side, the photographic image. We have a tooth resorption occurring around the 407 here and 408 here. 409 seems to be spared with this tooth resorption problem. You can see that there's gingival ingrowth into the resorptive lesion here and here, and these are telltale clinical signs that we'll see of a tooth resorption. If you look at the radiographic image, on the right-hand side, you can see the yellow oval and circle is showing you that there's quite marked type 2 tooth resorption occurring around the 407 here. So this would be a crown amputation technique, whereas 408 has a tooth resorption in this area here. We have an intact periodontal ligament space here, an intact periodontal ligament space here. So we should be able to extract that whole tooth. Now, one of the benefits of the CR7 software, the CR7 unit is made by IM3. One of the benefits of that software is you can do an inverted grayscale. So this is the inverted grayscale image from the previous radiographic image on the previous slide. So whatever is radiolucent, a black area becomes white. So you can see in this situation that we do have white, which is the periodontal ligament. You can see that very clearly around this tooth. You can see it quite clearly there around 408, but 407 you can't see the periodontal ligaments lost completely. So it is another tool in the toolbox that will help you differentiate between a type 1 and a type 2 tooth resorption. Here we have an example of a small type 1 tooth resorption in the crown, and this is in tooth 309, so you can see a little pinpoint tooth resorption there, which is it's a strange lesion. We don't often see a little pinpoint lesion like that. The radiograph on the, we'll just show you this lesion. Yep, there it is there. And if we expand that lesion, we've got a little probe that's sticking into the lesion there. The radiograph on the right-hand side, the right upper, shows you that the red arrows show you the lesion. There's a little pinpoint lesion, but there is a lesion extending down into the root of the tooth as well. So this tooth has an intact periodontal ligament around it, this tooth 309. So this tooth should be able to be completely extracted, and as you can see, the image, the lower right image, we've completely extracted this tooth, and we will smooth over the bone and suture the gingiva close. This is Drake, an 8-year-old cat, and we're looking at teeth 104 and 204. So these teeth here. Close-up of tooth 204 here. We do have some gingival recession there, so there is some periodontitis going on. If we radiograph it, this is the red oval, shows you tooth 104. So you can see again, this is a type 2 tooth resorption. We are losing the periodontal ligament at this area here, and this part of the tooth here is undergoing replacement resorption by bone. But clinically, the photograph shows you clinically that it all looks quite normal on a clinical examination. It's not until you take a radiograph that you can see the amount of destruction, and this is where often these crowns will just fracture off at this level. The tooth 204 is undergoing the same situation, the red oval here. So you can see periodontal ligament to about here and to about there, and then we're starting to lose the periodontal ligament space around that tooth, and this will also undergo the same sorts of situation where the crown may fracture at this point. This is a photograph of tooth 404. It has a uncomplicated crown fracture of the tooth, but if we radiograph it, we can see this tooth 404 here, that the root of this tooth is also undergoing replacement resorption. If you look at the root on the other side, the crown is fractured off here, and that root is also undergoing replacement resorption. So this is a type 2 type of situation, type 2 tooth resorption. This is the area 2 weeks post-surgery, so we actually did a crown amputation on tooth 404, and I've got a little video I can show you of that. And this yellow oval shows you the healed site of tooth 404 after the crown amputation, and the sutures have been lost. So here we have a short video on a crown amputation and intentional root retention on the cat in the previous slide. So you have a tooth 404. We're raising a flap around the tooth, just a simple releasing incision on the mesial side. We're raising that flap now to expose the underlying bone. Once we've exposed the underlying bone, we do a crown amputation where we cut the crown off, and protecting our flap, we use a round burr to remove the root of the tooth, as much of the root of the tooth as possible, with surrounding 360 degrees of surrounding walls. We just smooth over the bony walls, and that's what we're left with, and then we can suture it back over the top. Now I'd like to spend a few slides on oral tumors, other pathology, other anomalies that we may see in the oral cavities of cats. Here we have a cat with a suspected squamous cell carcinoma involving tooth 108. You can see the radiograph of that area. The clinical photo below is post-extraction of 108, but the yellow arrow heads show you the extent of the bone loss in this area, so you can see how dramatic the bone loss. This will be into the nasal cavity. The little red arrows will show you that even the zygoma, so the zygomatic arch would be coming through here and extending up to there. That's also being resorbed by this disease process. So this is quite a nasty malignancy that's destroying a significant amount of tooth structure and bone in that area. This is an example of a tumor in a very young cat. This is a feline ameloblastoma. You can see the tumor mass here, quite an extensive mass. You can see the 3D reconstruction from the CT scan, and the surgeon is planning where to remove this tumor mass. You can see on the radiograph on the right side here, the yellow oval shows you the extent of bony involvement. So you can see that the tumor is involving all the incisor teeth in this area. It's destroyed some of the incisor teeth in its slow expansion in this area. The surgeons decided that they're going to make the cut. The red dotted line is where the rostral maxillectomy is going to be performed, and so you'll cut straight across here, cut through the tooth roots of the canines. They can be removed once the mass is completely excised. Sometimes you can have two diseases occurring at the same time. So if you look at the radiographs on the left side here, we have what appears to be a tooth resorption occurring around tooth 304 and 404. The only thing that you comment on is that there's a lot more bony destruction in this area here around 304. This is the post-operative radiograph where both those teeth have been crown amputated and intentional root retention. Unfortunately, 7 months later, a mass started to grow in this area here, and that mass ended up being a squamous cell carcinoma. So you can see the 3D reconstruction of CT. You can see the mass, quite an extensive bony mass occurring, and lytic mass occurring in this area here. This is a case of gingiva stomatitis that was associated with persistent tooth roots. So you can see there's quite marked inflammation in this area here, a little bit of inflammation here, and on the left mandible, caudal mandible, marked inflammation in this area here. The referring vet did say that they did leave some tooth roots behind, so we'll go to the next slide. These are the radiographs of the mandible on both sides from the cat from the previous slide. You can see the white arrows here showing you up tooth roots. So we'll just point them out. There's a root here. There's a little bit of a root here. There's definitely a lot of root here, a lot of root here, and some root here. Also, you can see the pink arrows show you that there's some sequestra of bone. So we've got some bony sequestra here, some bony sequestra here. So in this situation, you would need to remove those tooth roots. We also removed this tooth here, 407, and we would smooth over the bone so that it was nice and smooth before we closed. So we'd make certain we do an alveoloplasty to smooth over that bone so that we get good closure. One of the complications we can see with tooth extraction in cats and in dogs is the loss of a root into an anatomical space. So if you look at the image on the left-hand side, the radiographic image on the left-hand side, you can see there's quite a marked tooth resorption occurring around tooth 309 here. There's a small lesion here, and there's a tooth resorption occurring there. So the veterinarian attempted to extract those 3 teeth. Unfortunately, one of the roots of 308, you can see the alveolus here, the black arrow, it's broken. So the alveolar floor, which you can see here, it's not present here, and you can see the root has entered the mandibular canal. In this situation, the best chance of finding this root is at the time of losing it. So you would raise a bigger flap if you haven't already, and you would remove bone in this area, keep on following the alveolus until you'll enter the mandibular canal. Just gently enter the mandibular canal, and there you should see the root sitting in the mandibular canal, and then you can remove it. This is a case of a long-standing jaw fracture that was left to heal naturally. So if you look at the radiograph on the left-hand side, we have tooth 304 here with most of its root resorbed. We have the fracture in this area here, and it's just about healed, but unfortunately it's healed with the tooth and this part of the jaw rotated outwards. So you can see the image, the photographic image on the right hand side. Here we have tooth 304. The fracture is healed, but the tooth is now causing a malocclusion, and it's not comfortable for the cat to eat. So we would need to extract this tooth. We ended up not doing anything about the fracture because it had healed, and so just removing the traumatic occlusion solved the problem for this cat. Finally, we look at why do we need to take intraoral radiographs. Well, this is a classic example of why we need to take intraoral radiographs. If you look at tooth 309, you can see that there's actually an extra root here. So you can see there's 1 root here, there's 2 roots and 3 roots. Now this tooth should only have 2 roots, so you've got an extra root. So if you didn't have a preoperative radiograph, you would not have known about this extra root, and sure enough you'd fracture it in this area here, and that may cause a subsequent complication with the healing of that area. So preoperative radiographs are really important to diagnose pathology, also to plan your surgical extractions, and also we recommend that you should take a post-operative radiograph to confirm the complete removal of a tooth. This is the final webinar in a 3-part webinar series. My name is Dr. Anthony Caiafa. I hope you enjoyed this webinar. If you have any queries or questions concerning this webinar, you can email me on toothdoctor@optusnet.com.au. Thank you.